Good evening, everyone, and welcome to the second episode of this year's Best Journal Club. My name is Dimitris Haloumas. I'm the fellow member of the Best Education Committee, and I'll be facilitating tonight's session. Our hosts for tonight are the Lister Upper Limb Unit, who will present papers on irreparable cuff tears and tendon transfers. Just to remind you that you'll be able to put your questions in the chat, and we'll try and answer them after each paper. Otherwise, the audience will be muted. This will hopefully last about an hour, and we aim to finish by 8 o'clock. I will now hand you over to Mr. Angelos Asiotis, who will introduce the panel and the presenters and lead tonight's session.
Thank you, Dimitris, and thank you to the Best Educational Committee for an invitation for tonight's session. My name is Angelos Asiotis. I work at the Lister Upper Limb Unit at the Lister Hospital in Stevenage. Today, we're joined by Kim Tabeliao, who is our fellow, who will start us off with the first paper that we will discuss. We'll then have Chuck Sanibweze, who is our registrar. He will talk about another paper comparing lower trapezius tendon transfers to another intervention that we will discuss. And we have our upper limb extended scope practitioners, Tim Andrews and Matthew Gilliard, who will talk about another paper on the non-operative management of this pathology. We're joined also by Adam Rumian and Harpal Appel, colleagues at the unit, and we'll discuss everything about tendon transfers with regards to non-repairable cuff tears. I'll start you off tonight with Dr. Tabeliao.
Perfect. I'm just waiting for my screen to pop up. There we go. Hi, everybody. Good evening. Thank you to Best for the opportunity to present today. I'll be discussing the paper titled Outcomes After Arthroscopically Assisted Lower Trapezius Tendon Transfer with Achilles Tendon Allograft, written by Cobra, Wright, and Murtry from Georgetown University and MedStar Union Memorial Hospital, published in the Journal of Shoulder and Elbow Surgery in 2024. The paper explores both MRI healing and early clinical outcomes following arthroscopically assisted lower trapezius tendon transfer for massive irreparable posterior superior rotator cuff tears. In the context of massive irreparable tears with persistent external rotation weakness, pain, and pseudoparalysis, tendon transfers have emerged as effective treatment options to reduce pain and improve shoulder function. The lower trapezius tendon transfer was originally described for the paralytic shoulder and involves harvesting the lower trapezius tendon muscle and extending its length or moment arm with an Achilles allograft, inserting it onto the greater tuberosity of the humeral head. The arthroscopic nature allows or avoids acromial osteotomy and deltoid detachment. And in comparison to the previous latissimus dorsi tendon transfer, as my colleague will later discuss, this transfer has been shown in cadaveric biomechanical studies to better restore native glenohumeral kinematics by allowing for an inline pull parallel to the infraspinatus and synergistic function with scapular retraction and shoulder external rotation. This study focused on the MRI healing data for the tendon transfer itself. It's a retrospective case series, single surgeon, single institution, with a minimum follow-up of 6 months. Importantly, they had very strict inclusion criteria, and one of which was having an intact subscapularis tendon, which we know clinically is not often the case, but they did not repair any additional rotator tendons in this study or on these patients. They very clearly described their surgical technique in their paper, as well as their post-op rehab plan. So I won't delve into that now, but it's really well written if anybody wants to go through that. They had 21 patients identified. 19 were eventually included in the results. Of note, 15 of the patients had had previous failed rotator cuff surgery, and 6 of those, which is about almost a third of their participants, had had more than 2 surgeries. Their primary outcome measure, which was the tendon healing on MRI, demonstrated a very impressive 89.5% healing rate at 6 months. Healing was stringently defined as continuous tissue throughout the construct, with any discontinuation on any imaging slice classified as a failure. Each MRI was independently reviewed by both a shoulder and elbow fellow, as well as a musculoskeletal radiologist, and there was no discrepancy reported between the 2 reviewers. They used this cutoff based on rotator cuff repair evidence. They had 2 complications and reoperations. The one was a harvest site infection in a diabetic patient that resolved with IV antibiotics, and that patient did well and returned back to their work and normal activities. The second complication was a patient that had early arthrosis and chondromalacia and had already had 2 previous failed rotator cuff repairs. They unfortunately went on to need a reverse shoulder replacement at 14 months post-op because they had minimal improvement and still pain with limited function. They were unable to return to work as they were labor-intensive work. There were 15 patients that had an external rotation lag sign preoperatively, and all resolved at final follow-up. And then there was noted a significant increase in external rotation and external rotation strength. There was also a vast improvement in all of the PROMs. On review, the strengths of the study, this is the first study reporting MRI healing data after an arthroscopically assisted lower trapezius tendon transfer. They had a standardized MRI protocol with dual independent reviewers, both a surgeon and a radiologist. They had multiple validated PROMs. And they had quite a clearly defined healing criteria, which was consistent with rotator cuff repair literature. They used consecutive patient series, which reduced their selection bias. They also provided us with relevant occupational outcome data, which was interesting. The weaknesses of the study, unfortunately, this was a level 4 evidence, so there was no comparative group. There was a rather small cohort size. And like I mentioned before, they had a highly selected patient group that they reviewed. This was a single surgeon, single center, relatively short follow-up. And the physical exam, the external rotation lag, was only examined or reviewed by the operating surgeon. There was no blinding of the MRI interpretation, and they did not correlate the healing versus non-healing outcomes, which meant that they assumed that healing led to good outcomes, which we'll discuss a bit later as well. So what this paper adds, it does show early MRI healing, which is useful for our rehab timelines. It supports the biomechanical rationale for the tendon transfer, and it reinforces the short-term functional gains that we're seeing. It reassures us that the tendon transfer can work biologically, but it doesn't really tell us if this is the best option for our patients. So it doesn't prove to us the long-term durability, but we'll discuss that a bit later because we know that this is for young patients and maybe utilized for more of a joint sparing or time delaying till inevitable surgery. And it doesn't prove superiority to other procedures because they never had a comparative study group. And they showed that there was healing, but they didn't correlate the healing to the better outcomes. And obviously this was a quite selective group, so it's not really generalizable to the rest of the population. So having a look at the literature update since this paper, since the publication, the evidence base surrounding lower trapezius tendon transfer has continued to evolve. One of the more interesting findings from the Delgado et al. Study was that a substantial proportion of their patients demonstrated lateral graft avulsion on post-operative imaging, but they still maintained meaningful clinical improvement. That raises the possibility that restoration of the shoulder biomechanics and force coupling may, in some patients, be more clinically relevant than the complete structural integrity on the MRI alone. And then another paper that was quite interesting showed that, or was reassuring that conversion to reverse shoulder replacement following the lower trapezius tendon transfer still produced acceptable outcomes. So suggesting that no bridges were burnt by doing an attempt at this tendon transfer to buy time. Overall, the current literature presents lower trapezius tendon transfer as a promising joint preserving procedure with acceptable complication rates. It's encouraging short and mid-term outcomes, but still limited long-term data from these studies. The discussion points. So drawing from the rotator cuff repair literature, tendon integrity has been shown to correlate with superior long-term outcomes. However, that causal relationship remains unproven in the context of this lower trapezius tendon transfer. This is a much more complex biological construct involving two healing interfaces. So where the Achilles graft has to heal onto the greater tuberosity, as well as where it has to integrate into the lower trapezius tendon. And it's not a native graft, or it's not a native cuff tissue. It's the graft tissue that also needs to heal. The authors of this paper also assume that healing drives clinical improvement, but they did not directly correlate healing versus non-healing outcomes. So it was more of an assumed relationship. And then they showed complete reversal of their external rotation lag sign, which is clinically meaningful and suggests restoration of the external rotation vector and improved biomechanics. But this was also only assessed by a single surgeon and susceptible to examiner bias. But if that is the true outcome, that's obviously very impressive. Then the arthroscopic assisted lower trapezius tendon transfer offers an attractive joint preserving option for young active patients with minimal signs of arthritis. But even in that select group, they still had one patient that they still had to convert to reverse shoulder replacement. So that highlights the importance of careful patient selection, but also careful patient counseling, especially in patients with labor-intensive jobs. And that's where the return to work was so interesting. The original results showed a really good return to work. But when you selected out only for those that had a labor or labor-intensive job, only 60% returned to work, whereas if you included the sedentary patients, it was over 75%, I think. So it's very important implication for preoperative counseling and managing patient expectations depending on what work they do as well. That's the paper. It's a very good read.
Thank you, Kim, for that. Before we have a chat, I wanted to ask Dimitris, have you got any questions that we'd like to discuss from the audience?
No, I can't see any, Angelos.
Kim, that was I agree with you. It was an interesting read for many reasons. You did mention something that I'd like to touch on as well. The follow-up was 14 months, if I remember correctly, or something around that figure. And they do mention, the authors, that it's a short follow-up. I wanted to ask you, in your opinion, what would you accept as a follow-up in a study if you were to consider this option as an offering to patients that come with this presentation, young patients with irreparable cuff tears? How long of a study is good enough for you to convince you, in inverted commas, to go for this option?
I think that's a very important point to note, especially with this joint preserving surgery that we're looking at. So personally, I think 14 months is good enough to demonstrate a proof of concept. Ideally, obviously, we would all like at least a 5-year follow-up before considering it a reliable, long-term option. But that being said, I don't necessarily think every joint preserving procedure needs to last that long to be considered valuable, especially when you consider the very specific patients that we're targeting the surgery to. So if it can provide meaningful pain relief and preserve the native shoulder joint for even, say, 2 years in certain patients, it's extremely worthwhile for them if they can continue with their current work or occupation and delay the reverse arthroplasty. But I think obviously this is very patient specific, and a discussion about balancing the functional expectations and their occupational demands and the potential need for the further surgery, whereas some patients might only want to have one surgical intervention. So I think a lot needs to go into patient counseling, but I think any patient would possibly want to try something that would preserve their native joint for as long as possible.
I agree. And when you were talking now, you mentioned the occupation a couple of times. Now, you touched on this point, which I noted as well. There's a bit of a hidden detail in the paper. I think they quote a return to work of 73 point something percent, but the 4 people who didn't return to work, all of them were manual laborers. So when you take that sub cohort, although obviously the sample size is small, you can't do subgroup analysis, only 60% of people with a manual job return to work. So how does this affect what you tell patients, or what do you think about sort of this figure?
So I think it's a great paper to quote when counseling patients, because it exactly demonstrates that. We don't want to give them this false hope that we can restore them to normal function. However, we do want to try and preserve their joint for and optimize their function while delaying the reverse shoulder replacement. So I think I would use this paper to demonstrate that, yes, we do get good outcomes, but may not be at the level that you are expecting. So I think it obviously depends on what type of work they're doing. If it is very labor intensive, this paper then shows that they may not be able to return to work, despite having some improvement in function from the tendon transfer and improvement in their POMs and delaying having a joint replacement. It may not get them back to the level that they are able to maintain employment. And I think that's an important thing to counsel them about from the beginning.
Absolutely, I agree. I mean, if you have a manual laborer who's young, still active, and they're going to have a low trapezius tendon transfer, this is big. This is a significant figure that has to be quoted. Yeah. Now, in terms of, you said that it's, and it indeed is the first paper, or one of the first papers, they used MRI to look at the integrity of the graft. If you had to design this study yourself, you can use an MRI, a CT arthrogram, an MR arthrogram. What would you go for, do you think?
So there's more evidence suggesting that MR arthrogram has greater sensitivity and specificity than just the standard MRI. It obviously, using a conventional MRI could miss subtle pathology, so partial thickness failures or incomplete incorporation of the graft, or defects in that interface. And with there being 2 areas that need to heal, the 2 interfaces, I think arthrogram would be more sensitive at picking up subtle discrepancies. But I think in this setting, they've selected a standard MRI as a less complicated option, more pragmatic, and obviously less invasive procedure for their patients. In my thinking when I was reading this paper, we don't routinely MRI our patients after doing a tendon transfer. I'm not sure if my indication for MRIing them would be if I'm suspecting that there might be a concern about graft healing or so they've given us interesting information, but I don't think that every unit would be able to even do a standard MRI for patient follow-up. So although MR arthrogram would probably be much more sensitive and specific to pick up subtle concerns of healing, I think the standard MRI would definitely show major discontinuation or complete failure, which is what we'd be concerned about.
Thank you very much, Kim. And thank you for your presentation. Now we'll move on to the second talk for the evening.
Just very quickly, Angela, well, there is a question or an opinion rather. I'll just read it. I think, so Heman Singh is saying, I think the procedure is good enough only for a very select group of patients. If we are only expecting the procedure to work for a couple of years till the eventual salvage procedure, it's hard to justify the risks versus benefits. Just a very quick opinion, if that's okay, before we move on.
Of course, and the health economics as well come into play. So let's move on to the next paper, please.
I do have one thing to say about that. We don't have the long-term outcome data, so we don't know how long these patients can expect the tendon transfer to work for. It may give better results than we anticipate, and having that long-term data might be helpful.
That's true. Thank you. So let's move on in the interest of time. Let's move on to the next talk. Thank you. Chucks, floor is yours. You're muted.
Good evening, everyone. Today I'm presenting this 2022 paper by Bakley and Kim. I'm looking at the latissimus dorsi transfer versus lower trapezius tendon transfer for posterior superior irreparable rotator cuff tears. So when facing young and high demand elderly patients, irreparable rotator cuff, posterior superior rotator cuff tears options are limited. Simple debridement and partial repairs only offer early gains and are reliably deteriorate over time. Superior capsular reconstruction has been plagued by high graft failure rates, especially when the underlying muscle quality is poor. And while a reverse solar shoulder arthroplasty is highly predictable, we want to delay or avoid it in a younger, active, highly active cohorts. So where reconstruction is not an option, or repair rather, especially in these Pate grade stage 3s or Guttale 3 or 4 fat infiltrations, tendons won't really reach the footprint, even with full mobilization. Therefore, tendon transfers remain our premier joint preserving alternative. Latissimus dorsi tendon transfer has decades of history, as was described by Gerber in 1988, with relatively good long-term outcomes. Lower trapezius tendon transfer has emerged as an alternative designed to address some of the latissimus dorsi's shortcomings, biomechanical shortcomings. So this was a retrospective comparative cohort looking at 90 patients in a single center managed by a single surgeon with a minimum of 2-year follow-up between January 2012 and June 2019. Importantly, these two groups didn't run concurrently, with the latissimus dorsi group being done from 2012 to 2017, and the lower trapezius transfer being done from 2017 to 2019. The posterior superior irreparable rotator cuff tears were strictly defined. All these patients had failed conservative treatment. They had a Guttale grade of 3 to 4, and the selection criteria was a Pate grade 3 of retraction and a Hamada grade less than 2. They all had to have an intact or repairable subscapularis tendon. And in the intervention was arthroscopically assisted lower trapezius tendon transfer, which with the comparison being the latissimus dorsi tendon transfer. Outcomes being looked at were both clinical and radiological, which they looked at the American shoulder and elbow surgeon score, as well as the activities of daily living requiring external rotation score, looked at active external rotation, acromial distance at 2 years, as well as VAS for pain and other parameters as well. So the surgical techniques were standardly arthroscopically assisted. On the latissimus dorsi side, the latissimus dorsi was harvested through axillary incision and through Krakow sutures, was then shuttled through the subarachnoid space and fixed with rich porosity. On the lower trapezius tendon transfer side, after harvesting the lower trapezius tendon from the medial border of the inferior scapular spine, inherently this tendon lacks native length to reach a great tuberosity. Interposition Achilles tendon graft was required to bridge the gap, with tenodesis performed during a pulvitar weave and a double row suture bridge at the supra-infraspinatus footprint. So there were no significant differences between the groups at baseline for age, sex, BMI, comorbidities, and symptom duration, with fatty infiltration being of the subscapularis tendon and teres minor. Both groups did have absolute Guttella grading of 4, even though they had a selection criteria of 3 to 4, but all patients in all groups had 4 at the end. And the preoperative, they did note that preoperative pseudoparalysis was present in about 11 patients in the latissimus dorsi group compared to 5 in the lower trapezius tendon transfer group, which was not statistically significant. But overall, baseline comparability was reasonable, to be honest. So both groups at 2 years clinically had significantly improved pain as well as functional scores from baseline, but 3 outcomes favored lower trapezius tendon transfer. These were active external rotation of nearly 55 degrees versus 33 degrees, which is significant with a p of less than 0.01. American shoulder and elbow score was about 73 to 83, which is a 10-point difference. An active forward elevation and pain relief was slightly better than the lower trapezius tendon and transfer group, but these did not reach statistical significance. Importantly, like I mentioned earlier, pseudoparalysis resolved in 10 of those 11 patients in the latissimus dorsi group and 4 out of 5 patients in the lower trapezius tendon transfers. There were also 3 axillary nerve palsies in the latissimus dorsi group, which were all temporary and resolved by 6 months. In terms of radiological outcomes, so acromial distance, which is a proxy for suprastability, did fall in the latissimus dorsi group, which in essence indicates the head beat migrating superiorly. In the low trapezius tendon group, this rose from 7.2 to 8.7, indicating the head was better centered compared to preoperatively. And these changes were both statistically significant. In terms of arthritis progression, there was 31.3% of the latissimus dorsi group showed hematograde progression at 2 years, whereas in the lower trapezius group, that was about 7.1%, which is a 4-fold difference, which was also statistically significant. And this does align with prior literature, with Gerber reporting about 30% of osteoarthritis progression after the latissimus dorsi tendon transfer. It's lots of words. The proposed mechanism being that with the latissimus dorsi, because of its extrascapular origin, this converts the humeral head from being a depressor to a glenodepressor at high degrees of abduction. And therefore, it can't really maintain stability the way the low trapezius will be able to. In addition, graft re-tear was noted in 1 of 48 patients in the latissimus dorsi group and 3 out of 42 patients in the lower trapezius tendon transfer group, which is numerically higher but did not have statistical significance. All these 4 patients needed revision surgery with a reverse total shoulder arthroplasty at the end, and the re-tear in the lower trapezius tendon transfer occurred at the Achilles allograft footprint, infraspinatus footprint junction. So why does LTZ perform better? The answer is biomechanically based on the diagram from the paper as described here. Ideally, as we know, the ideal tendon transfer has to follow the good line of pull, good tension, a good excursion, and should mimic the tendon it's replacing. When we transfer the LD, the force vector ends up being inferior and posterior to where the native infraspinatus pulls. And this causes, like I mentioned earlier, a glenoid compression rather than humeral elevation. With the lower trapezius, this originates in the spinal scapula and a cranial intrascapular origin, and the vector following transfer is closer to its native line of pull from the infraspinatus. So this is why it is biomechanically more advantageous. So in terms of strengths and limitations, the strengths include the fact that this is one of the earliest studies looking at direct comparison of these 2 techniques. Patients had good and well-matched baseline with similar disease severity. Being a single surgeon removes intersurgeon variability, but also there's also a disadvantage, which I'll mention in a moment. And they measured both clinical and radiological outcomes, and the MRI was blinded, was done by a blinded radiologist. In terms of limitations, this is a retrospective study. So selection bias and recall bias are inherently baked in. The non-concurrent design that we mentioned, the surgeon, or he or she, did the latissimus dorsi transfers first, for the first 5 years. If you look at it, his gains relative experience, and then proceeded to lower trapezius tendon transfer for the following 2 years. This, surgical skills improves in that time, referral patterns may change, perioperative care and rehab protocols would have evolved at that time. And those are things you can't really control for retrospectively. Being a single center, single surgeon study as well, so limits the generalizability in terms of, will this apply to a DGH or even less specialized unit. No power calculation was done, so the study was not formally powered. And I mentioned the graft tear rate was slightly higher, was higher in the lower trapezius tendon transfer compared to the latissimus dorsi transfer. And although this was numerically significant, this was not statistically significant. It beggars the case that if there was power calculation accordingly, that we would actually see a true difference in terms of re-tear rates. And they didn't really specify any pre-specify any primary outcomes, which increase the risk of in terms of false positives, in terms of picking what outcomes they really want to assess at the end of the day. And finalized 2 years, we mentioned earlier the previous talk, is quite short for a tendon transfer, and seeing the long-term outcomes. I think Gerber's paper in the Journal of Bone and Joint Surgery was at 2013 showed a minimum of 10 years, of which the arthritis curve does diverge for such a short period of time in this case. So how does this translate to our practice? Patient site selection and criteria is key in terms of this shows severe disease and something we can apply to particularly. This is Korean single center study, which limits generalizability in terms of the populace heterogeneity. Lower trapezius tendon transfer requires a case allograft, which obviously then talks about availability and surgeon expertise. And in the UK, for context, this probably means more centralization or to a specialized shoulder and elbow units. And in conclusion, both techniques did improve pain and function. Lower trapezius tendon transfer was superior for external rotation, ASES, Adler, AHD, preservation, with theoretically anyway, a fourfold reduction in arthritis progression at 2 years. And the authors did conclude that lower trapezius tendon transfer should be preferred in the active younger patients, where joint preservation is the ultimate goal. In my view, the data is consistent and it points in the same direction across clinical and radiological outcomes. The biomechanical rationale is supported by other studies and prior cadaveric evidence. But being a single center level 3 retrospective study with non-concurrent groups, it may not be enough for us to sort of change practice overall. But in a specialized elbow shoulder unit is something that's reasonable to look into. So what we really need to look at is randomized control trials or long-term data in terms of follow-up from these multi-center data for this.
Thank you, Chuck.
Thank you very much.
For the deep dive into this paper that, at least for me, was one of the first papers that translated a biomechanical idea and theory and demonstrated that it clinically makes a difference, as underpowered as it was and the short follow-up that you mentioned. I like that point that you raised, and I agree with you in the sense that at least for this single surgeon study, you start by doing LDs for 5 years, and then you convert into doing lower trapezius tendon transfers. So in other words, one would say, well, you get very good at it, and then you operate on the lower trapezius tendon. Of course, they'll do better, right? Also, another point to make is rehabilitation protocols change over 7 years, right? So I would expect just by that, perhaps for the LTT group to fare better. But a commendable study, I think, and one that I think proves, at least to me, that what we're doing as a unit, looking into LTTs, makes biomechanical and now clinical sense.
Clinical sense.
Dimitri, anything from the audience?
Nothing I can see now, no.
A point that you made as well, Chucks, is that re-tear rate. It sort of makes sense. You have two interfaces with the LTTs and a single interface with the LD. And you touched on that, I think. Of course, it's non-statistically significant, but it is significant. This is clearly an underpowered study, and to compare such numbers and decide.
I think I can mention as well. You have to have incorporation of allograft, which in itself has its own problems. I think we augment it in our units with hamstring, but in itself, it's not. There's no guarantee, is it?
Absolutely. Thank you.
Thank you.
Dimitri, if there's nothing else on this, I will pass on to Matt and Tim.
Okay, thank you. I'll present from there.
Perfect. So thank you for inviting us to come and speak tonight on the topic of non-operative treatment of massive irreparable rotator cuff tears. So the paper that we're looking at is the JSCS paper from Shepherd et al. In 2021, non-operative treatment of chronic massive irreparable rotator cuff tears, a systematic review with synthesis of a standardized rehabilitation protocol. So just setting the scene, we're aware that a proportion of massive irreparable rotator cuff tears will be asymptomatic. However, they can cause significant pain, reduction in shoulder function, and loss of strength and mobility. And we know that surgical management is not suitable for all patients, be that due to comorbidities, the severity of symptoms not warranting such, or indeed patient choice. We also know that there's limited evidence that exists regarding the optimal conservative management of these type of tears. We do have some literature from the Moon shoulder group back in 2013, which demonstrated that around 75% of patients with chronic atraumatic rotator cuff tears improved with physiotherapy and did not require surgery. But no, this study included both small, minimally retracted, repairable tears, as well as atraumatic, massive, irreparable rotator cuff tears as a single cohort. And there's been few studies that have addressed the efficacy of non-operative treatment modalities, specifically in the subset of patients with massive irreparable rotator cuff tears. And that leads us on to the question of, is non-operative treatment effective for chronic irreparable rotator cuff tears? And if so, what rehabilitation approach appears most beneficial? And that leads us on to the aims of the Shepherd article. So they wanted to present a systematic review to compile and review the available evidence to determine the efficacy of non-operative treatment modalities for the cohort of patients with massive irreparable tears. And a secondary aim was to develop a synthesized non-operative treatment protocol based on the best available evidence. So the study design looking at methodology was a systematic review following PRISMA guidelines, so therefore allowing for transparent and complete recording of the reporting of the systematic review. Looking at the databases searched, there was an extensive search carried out across multiple databases, with the search performed in May 2020. However, the authors did fail to indicate the time period within which the search took place. Was it from the inception of the databases or over a defined period that wasn't clear? The Boolean search terms included a wide array as listed here, but not limited to these, all of which you would expect to see in such search terms. And the analysis was a narrative synthesis only, as no meta-analysis was able to be performed due to the heterogeneity across studies. And therefore, the question is whether this was the most effective methodology for the secondary aims of this study. From a quality assessment perspective, there were two independent reviewers who assessed. There's the inclusion and exclusion criteria there that you can have a little look through. In terms of this, only English language studies were included, and this was noted to be a limitation by the authors in the review. They did include studies with defined irreparable tears, and we'll move on to this in a moment. But they also included surgical interventions were included if there was an independent analysis of the cohort treated non-operatively. So moving on to the definition of massive irreparable rotator cuff tear. The authors acknowledged that there are multiple definitions that can be used. They said the most common definition was included as a rotator cuff tear involving two or more tendons, a Guttaglia grade 3 or 4 fatty infiltration, and a Pate grade 3 retraction. However, when we looked into the individual studies, there was some variability across this. As such, the Agut study in 2018 actually included Guttaglia grade equal or more than 2, and therefore this calls into question whether this would truly be deemed to be irreparable, and therefore calls into question whether the populations that are being compared are the same. They came up with a definition via mainly MRI, but ultrasound was also used, as was arthroscopy. This is just a graphic depicting the search. It started with 308 articles, and this was eventually whittled down, as per the PRISMA guidelines, to 10 eligible studies. These studies range from 2002 all the way through to 2019, and there were 10 studies in total, 9 of which were level 4 case studies, 6 prospective and 3 retrospective, and 1 level 3 retrospective case control. So the overall quality of the evidence was low. There were no level 1 RCTs specific with a non-operative protocol available for inclusion. Looking at the data collection from these studies is outlined here, and they were looking at multiple different non-operative treatment modalities, including rehabilitation, exercises, injections, use of NSAIDs, etc., over various follow-up times. And there were multiple outcome measures used across the studies. They used MCIDs as per the WJA and JAIN where possible. So moving on to follow-up. Now, this is a kind of a relatively key point there was huge variation and a massive difference in terms of the extent of the follow-up of these 10 studies, ranging from 3 months all the way through to 4 years. And interestingly, the study success rate was quoted to be between 32 to 100% in this systematic review. And the 2 of the studies which reported 100% had the follow-up of 3 months. The authors did not do any subgroup analysis looking at the longer term follow-up, so potentially missed out on some analysis there. Looking at functional outcome measures, as I said, there was multiple, up to 10 different outcome measures used across the studies. So substantial heterogeneity and limited overlap between the studies. So whilst it was pragmatic and they did use MCIDs, not all of the MCIDs were validated specifically for rotator cuff disease, and therefore it's questionable whether the improvements can be determined to be clinically significant or not, and therefore the rate of success should be interpreted with caution, in our opinion. Moving on to the next slide. So secondary aim development following data collection. Studies reporting significant improvement were selected, and these were the studies that statistically had significant improvement with change exceeding the MCID in terms of patient outcomes. They were reviewed to extract the specific details of the non-operative intervention and protocol used. Although it was unclear how this process was completed and by whom it was completed. There were 3 studies that did not actually describe any of their treatment protocols and therefore were not used, and a further 3 who did not show any clinically significant improvement in patient outcomes, who again were also therefore not used, leaving 4 studies, which was the Ainsworth study, Christensen study, Gutierrez Espinosa, and the Levy studies, all of whom provided detailed description of their rehabilitation protocols while demonstrating a significant improvement in functional outcome scores. But again, it must be noted that the follow-up times for these studies vary between 3 to 9 months.
And when we're looking back at that rehab program, as we can see detailed here, the Yian paper wasn't included in that further analysis to meet the secondary aims. And it was really interesting because the Yian paper was developed off the back of the Levy paper in 2008, and both were using the Reading Unit anterior deltoid rehab program. When we look at the results of the rehab program and the frequency, then there's again a lot of variability from total contact time. So the Levy and the EM paper, they've got a total contact of supervised sessions with physio of 3, in comparison to the Gutierrez and Espinoza total contacts of 24. So again, introducing a lot of heterogeneity, which they did identify in the Sheps paper, and further discussed later in relation to whether supervised physio versus independent home exercise plan would give the same outcome. Now, when we look back at the demographic data that was presented, they said that there was a pooled total from 507 patients included within the 9 papers, and each of the studies had varying participant rates ranging from 10 to 162. But when you delve into the data a little bit more, as they presented in their tables, actually there was around 537 presented, but it wasn't clearly defined in their write-up. The average age was 69.2 years, which again is quite common for our population of patients. 75% of cases identified within the dominant arm, 54% are female. And again, that variability with average follow-up of around 23 months and duration of symptoms around 21 months. So again, leading to that chronic picture. Again, with the overall results, the reported success of non-op treatment ranged from 32 to 100%. But again, there was a bit of disparity within the write-up, because in the abstract, they talk around results of 32% to 96% success rate, whereas in the Ainsworth paper, which was only 10 patients, there was a 100% success rate. Most patients experienced some functional improvements and met or exceeded the MCIDs that was reported in the paper. And the synthesized protocol was looking at supervision of physio lasting at least 12 weeks of what they came up with. So again, they used those 4 studies that they reported to create quite a detailed protocol, with some really clear imagery relating back to their best evidence. But again, we question whether this was the best way to go around creating the protocol, and there was no consensus statement with specialist groups involved in the creation of this protocol, which again is a limitation. When you look at this proposed improvements in symptoms after doing an anterior deltoid or a cuff-related strength program for the massive irreparable cuffs, then there's again a lot of variability. So they're saying there's a high success rate, but actually in quite a few of the papers, strength and range of movement wasn't fully recorded. And the limitation of this wasn't really clear within the Sheps paper. They didn't identify that the limitation in strength by using things like handheld dynamometers or looking at other measures of cuff strength, such as grip strength, which has been further validated in further research. Again, range of motion, there are improvements in the mean in a lot of the studies, and some reporting full range, but again, it wasn't really clear, and that wasn't delved into fully within the write-up. When they looked at variability in the research, they identified that 5 studies also used injection therapy as an addition to physiotherapy. And there was a missed opportunity there for Sheps to really delve into that in a lot more detail, because going back to the original papers, out of the 5 studies, actually only 2 of them gave really clear detail of the process, but it still wasn't clear enough to say whether it was landmark guided or ultrasound or image guided. It didn't say the locality, although a few of the studies preferred to use subacromial bursal injections. Within the VAD paper, they did a sub-analysis as the group that was looking at conservative management and rehab. Out of the 40 patients, so were split into 2 groups. One was rehab alone, and one was looking at rehab plus an injection. And around 75%, so 9 of those patients had overall excellent outcomes as guided by the SRQ, in comparison to 60.7 that had rehab alone. But Shep did identify that obviously having an injection does pose a slight risk, and especially if those patients were then later going on to have arthroplasty. Now, was MCID met? So out of the papers that presented scores aligned with cuff-related tears or disease, then they identified that MCIDs were met. But again, there are still limitations when drawing conclusions because of the sample size. It wasn't going to truly reflect anything that we can draw statistical significance from, and therefore MCIDs were best placed, the author felt, for review. Now, they did come up with it, it was a really good paper and it was a nice read. They did address a significant clinical gap and provide a standard therapy benchmark with the protocol. The rigorous, because of the lack of scientific rigor there, they used MCIDs to validate patient outcomes, but there's still limitations. And there was transparency around the limitations within the data, and looked at quantitative meta-analysis was impossible because of the heterogeneity of the proposed studies and level 3 and 4 evidence. Now, part of the limitation relies on that low-level evidence and looking at selection and performance bias. There's, again, lots of heterogeneity, and it's hard to compare across groups. The exclusion of non-English studies have been omitted. They didn't also look at those patient groups of wider demographics, such as smoking or occupation, which we've already heard is really important. So looking at that return to function. They also didn't consider any analysis or reflection of patients that might have undergone a primary cuff repair, which then has subsequently failed, and what their options then are, and whether they respond as well to conservative measures. There is variability in the definition of success, and as we discussed with this paper, is the definition of success just avoiding surgery, or is it getting return to function, back to occupation, and that full range of motion? And there's a series of inconsistencies noted within the write-up, such as number of patients, reported success rates, as we talked about. Within the Gutellier grades in the selection, they advised that it was grade 3 or above, whereas if you look at a Goots paper from 2018, it advised of Gutellier a grade of 2. So we're not comparing apples with apples, we're almost comparing apples with oranges. And then citation errors when looking through the data in more detail, they cross-referenced the wrong papers. So the implication for practice, although non-operative management is moderately efficacious, and definitely a viable option for patients with poor surgical candidate or want to avoid the surgical risks. There is some data to support getting back in functioning. The standardized care, so they've created this 12-week rehab program, but actually when looking at the data, it may need to be wider than 12 weeks, so not limited to that. A multimodal approach of cortisone steroid injections and anti-inflammatories may be better to facilitate rehab. And we need to make sure that we're choosing appropriate prompts to validate that are validated with cuff tears if moving forwards. So obviously, when we're looking at the vigor, they've looked at a CASP appraisal. We've used the CASP appraisal to review, but unfortunately, within the paper, they failed to use any standardized measures to look at risk of bias. So they missed the opportunity to look at the Cochrane risk of bias tool or Robbins I version 2, which would have enhanced this study further. Again, we need to look at supervised or unsupervised exercise programs, which there could be a good sub-analysis, especially with the wider work in other areas, such as the Artisan trial of looking at getting patients going earlier and having that independent review. And obviously the exercise program, we need to look at the wider understanding of cuff activity, even though with massive irreparable cuffs, it's not just the anterior deltoid that's working. And Prof. Karen Ginn's work of looking at EMG studies on how the shoulder functions biomechanically and activates should really inform our decision when looking at rehab moving forwards.
Thank you, Matt, for that.
Any questions?
For that discussion. And what I take from this is there's a protocol. It's 12 weeks of supervised rehabilitation, and that's quite significant. Now, on the back of that, we've talked about rehabilitation and operative management. We've talked about the surgical approach. I would like to ask, if I may, and direct this question to Adam and Harpal. If I am in a unit and I want to set up an LTT service, logistically, learning curve wise, what do I need to think of? How can I do this?
Thanks, Angelos. I think the first And then the same principles apply as to any new procedure you're doing, which is you need support from your department. So you actually need to talk about the idea first and decide whether it's something you want to adopt or not. And second, you need to prepare. You need to prepare thoroughly because there's unfamiliar anatomy, it's unfamiliar principles, and there's unfamiliar techniques. And obviously, we work in a culture where patient safety is important as well. So we know from our perspective, we started off with the idea to visit the Mayo Clinic, to visit Bassam Al-Hassan to see him doing tendon transfers, and then COVID came along and cancelled that. So we had to revisit that. But there are plenty of other resources. So we actually spent a lot of time in the Cadaver Lab. We spent a lot of time watching online videos, reading the literature, and actually practicing the techniques out of the operating room first. And then our first few cases were done as dual consultant cases. And I think also patient selection is very important. When you start off doing a new technique or something unfamiliar, you really have to make sure you've got the indication for the surgery spot on, so you don't deviate from very accepted principles and norms. So it is basically about reducing the variability and reducing the room for error and complications as far as possible, and turning up to the operating room prepared. And of course, the other thing is to counsel the patient. The patient needs to know that you are trying something different. But the reason you're trying something different that you're not familiar with is because there is a very well trusted alternative, but it's in terms of reverse, it's a one-way street. So I think there are multiple facets to it. And for me and Harpal, it was a very interesting journey. Harpal, I don't know if you've got any other comments on that.
No, I think you've summed it up very nicely. There are lots of specifics that you can spend a lot of time going into with doing LTT. And I think it's probably too much to go into in this forum, but I think go and visit if you want to do it. I think if you can, go and visit someone who does it regularly, and really, really think about every single step along the way. What you don't want to do is start something unfamiliar and just going, oh yeah, well, we'll just figure it out on the day, because that's a recipe for an unpleasant time and a bad outcome. And I'd just like to reiterate, doing it together massively reduces the stress. The person who's not doing the active task at that moment is being monitored by the person who is doing it, and you get a lot of really helpful feedback that way. And it takes the stress level down and it stops you from making bad decisions.
Thank you. Dimitri, anything from the audience?
Can't see anything, no, but if I can take this opportunity to ask a question myself, if that's okay, that will hopefully help summarize the session, and that goes to all the panel. Obviously, you guys have shown through the paper presentations that both tendon transfers and conservative management is effective for these patients, and obviously that's potentially for different population groups. But how do you go about counseling patients when it comes to operative versus non-operative treatment? And that will hopefully, and you can hopefully tell us what your specific indications are for tendon transfers. And when you have decided for surgical management, how do you then decide for tendon transfers versus potentially SCR if you do them, or just a reverse shoulder replacement?
Harpal, do you want to take that?
Yeah, so I think we always think about non-operative treatment first, and the patients we've operated on have already been through that and have failed that. So that's why we're not thinking about doing non-operative treatment again. These patients have often failed a rotator cuff repair already. And they're often, your typical perfect patient for this is in their 50s, very active, and they've had a cuff repair that's failed. All of their cuff is wasted. So even if you repair it or do a graft, it's not going to contract. So I think you're in a situation where you're not burning any bridges by trying a tendon transfer. With regard to SCR, we did do it for a few years, and we found the results to be hit and miss, which probably reflects what other people have found with it. So yeah, that's in terms of decision making. If you've got someone who doesn't have any other good viable outcome, and their option is, wait 10 years and have a reverse when you're in your 60s, or try this and it might help you, and you're not burning any bridges by doing a tendon transfer with an LTT, then I don't think there's much to lose by trying it.
Harpal, if I may ask, how do you manage the subscap? Say you go in to do your transfer and you find a subscap tear.
Yeah, so this is a problem we had. So when our first few we had back in 2020, we were really, really careful and looked really carefully at the scan and made sure subscap looked pristine. But as you all know, we regularly found people with top edge tears of the subscap. And, we made a pragmatic decision. And this kind of reiterates the importance of having two consultants. So you're both there. We both thought this is very repairable. I don't think this is going to affect the end outcome particularly. So we went ahead and repaired the subscap straight away and then did the transfer. And every time we've done it, we've had a good outcome. I think if you were doing one with a full thickness subscap rupture that was retracted, I think that would be unwise. But I think if you happen to find a top edge tear, I wouldn't abandon the operation.
Thank you.
I mean, the other rationale to that, of course, is if the subscap is irreparable and they have got a complete loss of active external rotation, so the teres minor is deficient as well, and that the salvage is a reverse. If you're doing that reverse, you would probably need to transfer with that. So there is something to be said about giving it going ahead with a subscap repair. I mean, fair enough, if you can't repair the subscap at all, then you shouldn't go ahead with the transfer at the time. But if you can think, even if it's a large subscap tear and you can achieve a repair, then I think that's reasonable to go ahead with the transfer and monitor the outcome for 6 to 12 months. If you cancel the patient beforehand, that's the option. And then you can always proceed with a reverse subsequently, if that was a bailout option anyway, and you have your restoration of external rotation already. So it's quite a niche kind of situation and indication, but we'll just put that out there.
And I think the thing is it's very complementary with reverse. So I think we've done 5 or 6 in the last couple of years of reverse with an LTT, and the outcomes have been good so far. So it certainly hasn't put us off, and it only makes your implant work better. So I don't think you lose anything.
Thank you, Dimitri. Anything else from the audience?
Just a remark from someone to say that at BEST conference in Newcastle this year, there is a masterclass on the Friday on tendon transfers or repairable cuff tear speakers. Prof. Hachem from Spain and Gupta and Rajesh Nanda from the UK. So do check it out if you're interested. There is another question that I think we've partially answered. Hemant Singh is asking what's the panelist indications for tendon transfers? Just I'm conscious of time. Could someone just summarize them very briefly, if that's okay?
Adam?
Sure. So the clear indication is clear. So combined loss of external elevation and external rotation. So MRI scan, unviable posterior-superior cuff. And so that is the number one indication, with no arthritis. And then when you start from there, you actually expand your indications. So I would say for the purpose of this journal club, that is the indication. Once you are familiar with the technique and what can provide for patients, then you can expand that to more edge cases with, for example, intact but non-functional cuff, which you can get, and also combined with, as we've already discussed, subscap tears. So, but for sure, in terms of the official answer for that, it's irreparable posterior superior cuff.
Thank you. Now, I would like to thank everybody for their contributions today, and more than everybody else, the people who have stayed here for 1 hour on a Wednesday afternoon. And And I would like to, before I hand over to Dimitri, I would like to extend an invitation. If anybody's interested in this, more than welcome to contact us at the Lister and come over and have a look, and we can have a chat as well. Dimitri?
Well, this has been an excellent session, guys. Thank you, Angela, and the rest of the team for a very educational session. I certainly learned a lot. I'm sure the rest of our audience will agree with me. And can I just take this opportunity to remind you all to register for our annual Congress next month in Newcastle. Early bird rates finish on the 1st of June. And do check out our trainee session on the Friday of the conference at lunchtime, which it will be a bit different this year. We will be focusing on shoulder ultrasound for surgeons. Our next journal club session will be in September on elbow trauma from the Manchester University Hospitals team. Keep an eye out for that. Thank you all for joining tonight, and have a good night.